I was going off on. So I'm going to talk about first, what exactly is an EEG. So it's electrophysiologic technique for recording electrical activity from the human brain. And you guys have ordered different tests. So of course we have the routine, which is just a 20 minutes of the EEG. And we sometimes try to do provocative maneuvers. We try to stimulate the patient with light, or try to get them to close their eyes and try to fall asleep. And then we have these long-term monitoring with videos. And I think that's the main difference between a routine and a long-term. The long-term has the video. And we also have ambulatory EEGs where patient can take them home and do the take-home test as well. So this is basically a picture of what we see when we're doing EEG monitoring. So we can see these multiple computer screens where we can see the patient in the bed. So this picture is from EMU. So this bed is specially designed for epilepsy patients when we're trying to capture a seizure. So you can see the bed's very padded. You can see there's a connection to the wall, and underneath there we have the EEG for monitoring. And at big EMU centers, we can have multiple screens. So sometimes a technician is monitoring up to like 20 patients at once, trying to capture when they're having a seizure. And these are sort of these portable machines. So this is an ambulatory EEG. A patient can take this home and can wear them. And here, this is one of our portable machines. And so I actually have regular meetings with our EEG technicians, and they want me to remind you guys to, when you're moving the patients from the UCC or the ED up to the floors, to make sure to replug the EEG, the connection back to the machine and not to the walls, because the study is running on the portable machine. So when you reconnect them on the floor, you want to make sure you reconnect to the portable machine. Okay, so I'm rushing a little bit because I'm a little behind. So stop me if you have any questions. But okay, so here are some of the uses for the EEG. So there is a big difference between a normal brain EEG and a very abnormal one. So there's normal frequencies and then there are abnormal frequencies. So because of these changes that occur to the EEG when the brain is abnormal, we can use it to evaluate cerebral function. And the one that we all know about are to diagnose seizures. So seizures can have different symptoms. Some seizures have motor symptoms. It's very obvious. We can diagnose clinically. Some seizures are purely with altered awareness. So we can't really prove it unless we use a EEG. And also EEG can also help us localize the lesions. So if there's a brain tumor, then obviously the EEG signals over that part of the brain is abnormal. So this is just for your information. So sometimes the EEG can also help us with surgery. So depending on how sedated a person is during anesthesia, the EEG can be very slow or totally flat. So anyway, there are some surgical applications of EEG. And of course, in the ICU, it's also used for live monitoring, right? So in the ICU, what we're doing basically every 15 minutes checks of the brain, and it can be very difficult to move a patient from the ICU to get an imaging scan, for example. If we suspect they're having a stroke, or let's say vasospasms, especially vasospasm, these are things that could happen very quickly. And sometimes if you can't get imaging, it can be shown on the EEG. Okay, so there's a comment in the chat about Qualtrics. Okay, all right. So I'll let Linda help you with that. Okay, so all right. So this is just more basic information about how we do an EEG. And this picture of the brain is to show you the basic neuroanatomy, right? And the neuroanatomy is really important to help us read EEGs because these electrodes are placed on certain locations of the brain. So this is a typical, on the right is a typical diagram of where the electrodes are placed. And if you know neuroanatomy, you can really understand the naming of these electrodes. So for example, in the front of the brain, it's called the frontal lobe. And that's why this electrode here is named FP1, the frontal polar 1, and F3. So this is really important to get familiar with because when we're reading EEGs, each electrode has a different name, and you really need to correlate each electrode name with where it is located. Because, for example, if you have a seizure over the frontal region, it'll show up in the F3 electrode, right? So if you see some abnormal activity in F3, you can correlate that to the anatomy, which is the frontal lobe. So here, in terms of the basic anatomy, you have the frontal lobe, the parietal lobe, the temporal lobe, the occipital lobe. So this is kind of this basic review, right? So frontal lobe F, temporal lobe T, parietal lobe P, occipital lobe O, right? And the other thing I want to draw your attention to, so there are different numbers. And so besides the F, C, T, P, and O, there's also numbers. So by convention, and I'm going to repeat it a few times because this is really important for when we start looking at EEGs. By convention, the left side is odd. So 1, 3, 3, these are all on the left side. And the more lateral it is, the higher the numbers. So this is more closer to the middle. So it's 3. And as we go further out, this is 7. So F3 is midline, F7 is further out. And then on the right side, it's the same thing, but it's just even numbers. So FP2, F4, C4, P4, and O2. So I hope that's very clear. You know, this is the first part of the EEG, and we have to just make sure everyone's on the same page because this is how we're going to read EEGs. Okay, so this is kind of a busy slide, but the main takeaway that I want to show you is that basically we have these neurons called pyramidal cells, and they're called pyramidal cells because they're shaped like pyramids, and because they're all aligned in a certain way, they can generate they can generate negative or positive electric potentials on the outside of the cells. So basically, we're capturing this extracellular electrical potential, and it could be negative or more elective, and that's really what we're capturing with the EEG, with the surface electrodes. So as you can see, the surface electrode is all the way out here, and it has to pass through skin, skull, all these blood vessels, all this space, and also to get to the surface of the brain where all the electrical activity is occurring. And so as you can imagine, the only things we're really picking up are if large amounts of neurons are synchronized and having the similar electrical charge. So the signal has to be large enough, I mean, there has to be enough neurons generating it for us to detect it all the way on the surface, okay? So here it's the same diagram of the electrodes, and now we're going to translate these electrodes into something we see on the page, right? So this is something called a montage, and this is a montage that, you know, if you watch the bedside and you look at the EEG, this is a montage we use. A montage is basically how we connect, how we get electrical signals by comparing different electrodes. So for example, so here, looking at this EEG, we have this first line, which is FP1 and F7. So that's here, FP1, F7, right? So that's comparing these two electrodes, and comparing these two electrodes, this is the signal that's outputted onto the EEG page. And then you can combine, so this is FP1, F7, this is F7T3, so it's F7T3. So we can combine these into pieces of left and right. So this part is called the temporal chain because these 4 electrodes are basically going from front to back on the left side here, right? On the outer part, it's called temporal because the temporal lobe of our brain is on the outer aspect of the head. Okay, let me see, there's a question. Okay, Sylvia. So Sylvia, so that's a great question. Okay, so that's a great question, Sylvia. I'm really glad you asked. So C is not cerebellum, so C is central. So cerebellum is actually the back of the brain. Cerebellum is all the way down here. It's too far. It's basically below the cortex. I wish I don't have a picture of the cerebellum, but cerebellum is too far down, and the cerebellum doesn't generate typical seizures or activity. So the C just stands for central. Basically, it's called central because it's right in the middle of the brain. It doesn't actually correlate to a lobe of the brain. There's something called central sulcus. Let me go back. Let me see if I can go back to a previous lecture. Yeah, so there's something right here called the central sulcus. The central sulcus separates frontal and parietal lobes. So the C just correlates to the central sulcus. That's all it is. Okay, but that's a great question. So everyone, please feel free to type in the chat and I can answer right away. So, I'm trying to explain this and I realize this is super, as I'm trying to explain this, this sounds really complicated. So please feel free to stop me. All right, so just remember, so this first set is called the left temporal chain. And then here is a central chain, right? So here, so FP2, F8. So FP2, F8. Oh, I'm sorry. I'm getting myself mixed up. So FP2, F8. So this is why when you're reading EEG, the first step you do is you have to look at all the numbers. So this is a left temporal chain, and this is a corresponding right temporal chain. Do you see it? So FP2, F8, right? So just look at the first one, FP2, F8, you can see it's on this side. So left and right. So the way this is set up is very convenient for us to compare the left versus the right. Okay, so this is a left temporal, this is a right temporal, and now moving on. So now we have the left central and the right mid. I'm sorry. So the left midline and the right midline. So this is FP1, F3. So FP1, F3, right? So when you're looking at EEG on the wall, you just have to look at the numbers. So if it's odd, it's left. If it's even, it's on the right. And then you just have to remember the bigger numbers are further out of the temporal region and the smaller numbers are the midline numbers, okay? And just rounding out, so FZ, CZ, CZ, PZ, that's just these three electrodes right down the middle. And then down here, so for each EEG, we always do an EKG. We always have an EKG to monitor the heart as well. And so down here, just remember, we also have the EKG. Just don't, that's not the brain. That's just the heart, a single channel EKG. All right, everyone with me so far? Okay. So moving along. So these are basically the three words we use to describe any EEG findings. So we look at the frequency, right? So looking at this, there are all these waveforms. So when we measure when we record the electrical activity, it forms these waveforms, and it could be fast, and these could be slow. So we describe them with frequency, and then location, obviously, right? So where is it? Is it here? Is it here? Is it left side or right side of the brain? And then we also talk about morphology. So in terms of morphology, we talk about amplitude. Is amplitude just how big the waves are? Is it big? Is it small? Is it tall or short? And we also talk about polymorphic and rhythmic. And so I'll give you a few examples. Okay, so here's frequency. So this is kind of a busy slide, but I'll try to simplify it. So depending on how fast it is, how fast the waves are. So this is electrical waves that's going through the brain. If it's very slow, it's delta. If it's normal, it's alpha. If it's very fast, it's beta. And you can see, depending on how fast and slow it is, it has a very different image. And I think, if you practice just looking at the EEG at the bedside, eventually you get a sense of how fast it is. And the other thing is, when starting out, when I'm teaching the fellows, like we're literally counting it, because we're literally counting these waveforms to figure out if it's alpha or theta, right? So alpha is generally between 8.5 and 12. So I'm literally at the computer with the fellow counting 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And this is 1 second, right? So if there's 10 of these in 1 second, that's 10 hertz. So that's alpha. Okay, I see there's another question. Okay, so the question is raw EEG, right? So what I like about, so raw EEG is just ultimately what's collected by the receiver. So what this diagram is showing you is another important concept, which is that all of the different frequencies can be combined together, right? So usually when we're recording EEG, so this is a raw recording, I mean, this is directly from the brain. When we're recording this, it's usually not one frequency separated, right? It's usually not beautiful like this. It's usually multiple frequencies layered on top of each other. So you can see, so there's some delta, and then in between, do you see how this fuzzy stuff is the gamma and the beta. So this is a raw EEG that's not processed. So usually the raw EEG needs to be processed so that it's visualizable, right? But it's also important that when you're reading the EEG to understand that usually we're not looking at just one frequency. There's also this embedded smaller stuff, right? So you see the big delta, and then you see inside it, there's also on top of that, there's all these smaller frequency. And that makes sense, right? So the brain is not just one frequency, the brain is multiple frequencies. Okay, so let me see. So that's, okay, so I think that question is answered. Okay. All right, so that's a great question. So just let me know if there's anything else going on, any other questions. Okay, I really like how there's a lot of questions so far. It means that people hear me and it all makes sense. Okay, so here, with the EEG, we also talk about location. So on this page, you can see, so you can see like all the electrodes look pretty much similar, but except here, right? So T8. So remember, 8 is a big number, and 8 is also an even number. So this is right, and so this is the right side, and it's more on the outer side of the brain. So this is the more temporal lobe. So on the temporal lobe, you can see this big slow activity. So that means that there's a lot of slowing. So we say that the slowing is over the right temporal region, right? Because everywhere else you can see is pretty similar. So all of these regions are similar, and this is the one that's very slow. So this is where the abnormality is, where all this big delta wave, right? Delta means 1 hertz. So this is a big 1 hertz activity. And then we talk about different morphology. I think the main ones that I think for you guys to know are sharp waves, right? So sharp waves are basically areas of the brain where there's seizure activity. So the main 2 terms we use are sharp and spike. So sharp waves, they really stand out from the background. They look very different from what the normal EEG looks like. It just looks very abnormal. There's this pointy thing jumping out off this baseline. So these are called sharp waves, and spike waves are basically the same thing. So spikes, it just looks sharper. It looks more narrow. But basically, spikes are more narrow sharp waves. And one of my mentors says spikes, they look very uncomfortable to sit on. So if you just see how pointy it is, so this is a spike wave. And also sometimes the spike wave, there's also a slow wave followed afterwards. So it's called spike and slow wave. So if you read our EEG report, a lot of times if we say a spike and slow wave, this is essentially what we're talking about. And sometimes there's several spikes together, and that's called polyspike. And then sometimes there's a polyspike and wave. So it's similar. So you have these multiple spikes followed by a slow wave. So these are all the different shapes of the different waveforms, and that's what we call morphology. So is it tall? Is it short? Is it sharp? Is it spiky? So these are some of the terms we usually choose to describe the morphology of the EEG finding. And also, so these are more slow waves. So these are more broad. These are more slow activities. And then these are a bunch of other terms that, I just want to let you guys know that they're out there that we use to describe the EEG findings. Okay, so we talked about frequency, location, and morphology, and now, so I'm going to talk about a systematic way of looking at EEGs, and this is literally what I talk to the fellows. So whenever we open EEG, the first thing I ask the fellow is the patient awake, drowsy, or asleep, right? So the EEG is going to look very different depending on if they're awake, drowsy, or asleep. So I always ask them, what state are we looking at? And then we look at the background. Is the background normal? Is it slow? And then we look for any asymmetries, right? So left-right asymmetry, looking for asymmetry to see if there's any focal abnormality. And then we look at epileptiform activity. So if you could just do these 4 things, if you could recognize the state of the EEG, the background, the asymmetry, and the epileptiform activity, I think that's a great start. That I think that would be very useful for your ability to interpret the EEGs. And I have to give credit. So there's a website called www.learningeeg.com. So I took some of their slides. So I feel guilty, but I definitely want to give them some credit for having some great examples of how to read EEGs. Okay. So this is this slide is very important because this is basically the normal awake EEG. So let's just orient ourselves because the montage or how the EEG setup is different every time. So again, this is F3, 3, 3, P3. So this is on the left side, and because the numbers are small, these are basically the midline ones, right? So this is left, F4, C4. So this is right. And then this is F7, right? F7T3. So this is a temporal lobe. So this is the temporal region on the left. This is T4. So this is temporal region on the right. So how do you know this is awake? Well, what's special about it? Okay, so there's a lot of fast activity. It's lower amplitude. Everything's very fast. And there's these big artifacts, right? So these big artifacts so this particular one is just eye movements. And here, this big deflection, so this is not generated by the brain. This big deflection is caused by eye blinking. So as you close your eyes, the eyes will roll back into the head. And because the retina is negatively charged, it creates this deflection as it's moving. Okay, and here, so what happens is when the patient closes the eye, there is this sinusoidal waveform that occurs, and it's called the posterior dominant rhythm. And normally this should be 9 hertz. So this is literally what we do in the EEG region where we count it. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I think I counted 10. And each line, each division is 1 second. So there's 10 for 1 second. And that means this is 10 hertz. So this is a 10 hertz posterior dominant rhythm, right? So that's totally normal. So in a normal adult human being, it should be from 9 to 12. So if it's between 9 and 12, this is totally normal. And this is what you can see when they're awake, but when their eyes are closed. Okay, so with our patients, it's very rare that we see this, right? Like usually they're ordering EEGs on abnormal brains. So it's very rare that we see a nice normal brain with a posterior dominant rhythm where you could count the frequency and you can count to 10. So this is very nice. We have to remember this. Okay, so this is drowsy. Okay, so when it's drowsy, there's less there's no eye blinks, right? So when you're awake, when you're drowsy and when you're resting, there's less eye movements. And then there's something called these slow roving eye movements when someone's falling asleep, when their eyes are closed and they're drowsy, there's these slow roving eye movements. There's a little bit less muscle artifact. And you don't see the nice 10 hertz posterior dominant rhythm anymore. So everything is getting more flat and there's less activity. So that's drowsy. So here we get to sleep. So this is the different stages of sleep. So this is stage 1 sleep. So it's not important to know all the findings of sleep, but just to know, but you should just know that some of this pointy looking stuff, during when they're awake and they're having this is abnormal, but during sleep, this is totally normal. These are called vertex waves. They're just features of sleep. And that's why it's so important. And that's why the first thing I do when I sit down with a fellow is to ask them, what state are we in, right? So this is awake and this is asleep. So you can see how from awake to asleep, this looks totally different, right? And you can see, so when you're sleeping, you see this stuff. This is very slow compared to this is what we call slow waves during sleep, right? So if you see this slow stuff during a wakefulness, that means the brain is abnormal. That means the activity is too slow. But if you see this during sleep, this is completely normal. So that's why the first thing you do when you sit down to look at the EEG is what state it is. Although at bedside it's very straightforward. Just look at the patient. If they look awake, they're awake. But you can certainly go to the bedside and compare. Look at the EEG and see if they're in deep sleep or not. If you're in deep sleep, you see these slow waves and you see these vertex waves. So this is stage 2 sleep. So the key part of stage 2 sleep, something called K complex. So you see this really big slow wave, right? And you see in all the electrodes, and it's followed by the spindly stuff. It's the spindly looking things. And so this is a sign of stage 2 sleep. Again, if you see this one, they're awake, this is very abnormal. But if you're asleep, this is very reassuring. Okay. All right. So now we're done with the normal. So now we're going to the abnormal. So this is the best example of abnormal that I could find. It's a little blurry, I apologize. But here again, you see the big deflections I was telling you about that shows the eye movements. So these are the eye movements in the front again. But instead of the nice alpha, the nice 9-10 hertz frequency, the background looks a little bit slow. Just all this activity is just very slow looking. And again, each one is 1 second, so we can even count these. So 1, 2, 3, 4, 5, 6, 7, right? So remember, each division is 1 second, and I only counted 7, right? So again, I counted 7. So 7 is very slow. again, in normal people, it should be 9. So 7 is abnormal. So this person could be older. This person could be taking some medications that's causing brain dysfunction. So that's probably why it's slow. Okay. Okay. All right. So I don't know why it's a little bit off the midline. While I was looking at these, it should have been more midline. So this is a brain that's even more slow. So this is a person whose brain has something called burst suppression. So burst suppression is exactly what it sounds like. So there are these bursts of brain activity, and then it's totally flat for, look, here looks like 1, 2, 3, 4 seconds, right? And then you have another burst, and you have a slowing. So usually burst suppression is for patients who are sedated. And a lot of times, if our patient is in status epilepticus, sometimes we put them in burst suppression. And if you're the NACUs, we're increasing the bursa, we're increasing the propofol until we reach burst suppression. So this is what burst suppression should look like. We should have, the burst should be about 1 to 2 seconds. And here you should have 4 seconds of basically flat EEG, and then you have another burst. So when you see this, that means we're at goal, we've reached burst suppression. And here is an example of anoxic brain injury. So here you can see it's totally flat, the brain's totally flat, and then inside the burst, instead of seeing more normal looking activity, it's all these like very sharp, very high amplitude stuff. So as I was saying before, so the EEG can help you determine how severe the brain dysfunction is. So if you see something like this, where the EEG is totally flat, except for a few of these bursts of these angry sharp waves, that's a very bad prognosis, right? That's a very, very injured brain. Okay, so now I'm going to talk about focal slowing. So this is the image of like this diffuse, so it's slow everywhere. So now I'm going to talk about more what happens when there's slowing in just one part of the brain. So when there's slowing in just one part of the brain, that means that part of the brain is not working well, or it could mean there's a brain tumor, or there's a stroke, or there's some hemorrhage. Just anything that's particularly wrong in that particular region of the brain. So this is an EEG that I had, and I do apologize. It's a little bit subtle, but I think we can see it, right? So again, just to orient you, so 3 is odd, so that's on the left side, and this is on the right side. So left and right, and this is also left, and this is right. It might be a little bit subtle, but if you compare the left to right, you can see that there's some slow activity. So this is what we call 3 Hertz. So this is 3 Hertz activity that we don't really see here. And I think comparing the left temporal to the right temporal, you see it's more obvious. You see these big slow waves. I think, to be fair, this is a little bit subtle because I think there's some slowing on that side too. But I think overall, if you look at this page, you can see this is left and this is left. If you compare left to right and compare left to right, I think there's some obvious delta activity on the left side compared to the right side. So that's focal slowing. And right. Excuse me, let me just look at my slides. Okay. I'm just gonna need to pause for 1 second because something's wrong with my slides. The images didn't down properly. I just need to give me 1 second to download the images. Okay, can you see the slides? Okay, so, okay,
yes, we can see them.
Okay, all right, I don't know what happened. Okay, so here's what I'm trying to show you. So this is a focal slowing, and then here's the CAT scan of the brain, right? So this is a person who had surgery, who had part of the brain tumor removed. So the left side is very abnormal, and that corresponds to this EEG, right? So this is the left side of the brain that's abnormal. Okay, all right. So of course we need to do some practice, right? So let's use what we learned. So let's talk about states. Is this patient awake, drowsy, or asleep? Can someone just type? Can anyone just type the answer in the chat? Does anyone want to volunteer to just Okay, let's see what everyone said. Yep, everyone, yep, Sylvia Lynn said awake. Yep, absolutely agree. So this is awake, right? So you can see, so this stuff is the eye blink. So there's some eye blinks, and this is a muscle artifact, and you can see that the nice 9 Hz posterior rhythm. This is the alpha rhythm. So this is a awake EEG. All right, great job, guys. All right, so let's do the next one. Okay, all right, so this one, so this one, so where, okay, so I think the question I want to ask is, where is the abnormality? Is it left or right that's abnormal? Does anyone want to tell me which side is abnormal, left or right? There's only 2 options, so you could definitely, yeah, okay, all right, thanks guys. So thanks to it, so it's left, right? So the left side, you can see all this very slow activity, right? So let's remember, so slow is bad, slow is something is wrong, whereas the right is faster, it's more normal. Okay, so let me start over. So this is 3. So if it's 3, that means it's on the left. If it's 4, it's on the right. So if you look through this, and I realize I'm going really quickly, but so 3 is on the left, 7 is on the left. So all the left stuff is very slow. All the right stuff is very fast, right? Okay, so I hope that's clear. All right, so let me move on to the next slide. Okay. All right, so same question. Is this awake, drowsy, asleep, or sedated? Well, what do you guys think? Any guesses? Yeah, okay, great. Yeah, it's just sedated, right? So it's probably sedated, and it looks like burst suppression, right? So there's a burst of activity, and it's totally flat, and then there's a burst, right? Okay, great job. Okay, so I think you guys definitely got this. All right. All right, so moving on. So let's talk about epileptiform discharges. So what are epileptiform discharges? So these are abnormal activity that occur over area of the brain that has cortical hyperexcitability. So these are the parts of the brain that's primed to have seizures, primed to have abnormal activity, synchronized activity. So when we're talking about epileptiform activity, we're talking about sharp waves and spikes, right? So sharp waves are 200 milliseconds. Spikes are basically similar to sharps, but shorter. And sometimes these sharp waves can be periodic, meaning they can occur back to back. And we'll look at some examples of what these are. Okay. Okay, so here is an example of epileptiform discharge. So I'm going to do the same thing. I'm going to try to orient you guys with each EEG, okay? So again, so F3, C3, so this is on the left. This is left to midline. This is right to midline. And then T3, so this is the left temporal and this is right temporal, right? So if you go down, so this looks like a kind of a normal background, but here, and this is what I mean by it standing out. So this is all what the EEG background looks like, and all of a sudden there's a burst of this activity. This looks very different from what the usual EEG background looks like, right? So if you notice, so this activity is occurring in the temporal lobe, and you can see it in these electrodes, right? So the F7, T3, T5, and O1. So I just want to point out that there's 2 phases. So this part is pointing down and all of these are pointing up. And then there's a reversal. So the reversal occurs right here at F7, right? So that means F7 is where the discharge is. And I'll have a diagram to explain why that's the case. So this is basically a picture of what a seizure discharge looks like. So let's say, for the sake of argument, the seizure discharge occurs at C, right? So that means the potential here is most negative. It's 30. It's minus 30. So because the discharge is here, it's highest here, but as you go further out from it, you can still measure it. So even when you're at B, you can still measure it, but the number is lower, right? So it's not as negative, it's -10. And when you reach A, it's essentially, you don't detect it at all. So this is a mathematical explanation for why there's a phase reversal. So if you subtract A from B, you get 10. And then if you go, so you get 10, and when you compare A to B, that's why you have this smaller deflection. And then when you go from B to C, you do the math, you get +20. So you have this deflection. And then when you cross over the discharge, and when you go from C to D, you do the same math calculation, you get -10, then -20. So you go from these positive numbers to a negative number. So that's why you have a phase reversal. I don't think you need to understand the math precisely, but just understanding that when you have a seizure discharge in C, just understand that it's basically like dropping a pebble into a pond. The discharge spreads out through from close to far, and it looks different depending on if you're far or close. And having this knowledge allows us to locate, especially in this EEG, exactly where the seizure discharge is coming from. We can say it's coming from exactly F7. Okay. All right. And so this is an example of lateralized periodic discharge. So you see it in sign out and reports all the time. So that's just what we call LPD. So that's where we have a bunch of these epileptiform discharges back to back. So this is what we call 1 Hertz, meaning 1 per second lateralized periodic discharge. So it's 1, 1, 1. So of course, these could be fast or slow. So they could be occurring 1 per second, 2 per second, or 3 per second. The faster they are, the more concerning they are, right? So this is 1 Hertz LPD, which you'll see on sign out, which is concerning, but not particularly so, right? If it goes 3 Hertz LPDs, now we're worried about seizures. Okay, so what exactly are seizures? So I was doing this lecture, I was thinking to myself, so seizures could be a whole 2-hour topic on its own. So I'm trying to summarize what seizures are. So seizures are abnormal. They're organized, evolving bursts of cortical activity. Okay, so Vikram was asking, are these raw EEGs? So these are processed. So going back to the previous slides, so these are all processed EEG, meaning they go through a certain filter, right? Because there's a lot of noise, so they go through a lot of noise. We filter out the noise, the very, very high frequency gamma stuff, which is not from the brain. So these are all filtered EEGs. So anyway, so back to seizures. So I think the key part is that seizures are organized and evolving, right? So seizures have to tell a story. They shouldn't just appear and disappear. Usually they start out slow, they ramp up, and then slow, and then there's a ramp off period. So that's how you help. That's the main feature that helps you determine if it's a seizure or not. I'm just gonna mark this as done. And I'll give you an example of it. And seizures can start focally, meaning it starts from one place, or it could be generalized, meaning it starts from the entire brain is affected by it at the same time. And again, the symptoms of seizures can be very different depending on where it started. So if it started in the motor region of the brain, you can have shaking movements, basically called tonic-clonic movements. If the seizure is occurring over a sensory part of the brain, it can cause numbness, tingling. Sometimes you can have abnormal smell. If it's occurring on the back of the brain, you can have hallucinations. It could be simple or complex. And there's also an interesting thing about loss of consciousness. So if the seizure is only occurring over half of the brain, usually you should be able to maintain consciousness. I mean, obviously you'd be confused, but you can usually maintain consciousness. If you have the seizure affecting both half the brain, then you'll pass out. You lose consciousness, and you'll drop to the floor. It'll be very very severe. I mentioned this because sometimes we talk about syncope, right? So if someone passes out, that's one of the differential diagnoses of someone passing out between a seizure or a syncope. So usually, if you're having a passing out from a seizure, it has to be a generalized seizure. Both sides of the brain have to be affected. Okay, so this is an example on the EEG of a focal seizure, and the main thing I want you to take away is that with each seizure there's a ramp up period, right? So on my eye, I think I see some sharp stuff here. So this is probably where it starts to get going, and here you can see the amplitude or the height, how tall it is. It's about this height, and you can see the height of it gets higher and higher and higher, and for lack of a better word, looks angrier and angrier. So this is how a seizure should start. It should not just start out of the blue. It should not just start out of the blue and doesn't change. It has to have a ramp up. The seizures have to ramp up in this way. The amplitude gets higher and higher. And this is the next page. So initially the seizure started on the left temporal region. Now it's spread to the entire left hemisphere, right? So now, so that's the other part of seizure. They ramp up and they spread out. That's how every seizure works. And once it's spread to a certain point, eventually the brain's mechanism for stopping a seizure kicks in. So all these internal mechanisms kick in, and anti-seizure mechanisms kick in, and the seizure starts ramping down, and now the brain goes back to normal. Okay. And this is an example of generalized seizure where it's not starting in one particular part of the brain. It's that the entire brain starts having a seizure, and a little bit similar, right? It speeds up a little bit, it slows down a little bit, and here you can see it's very slow. It slows down, and then eventually it goes away. And just to complicate things, there's something called triphasic waves. So triphasic waves, it's called that because tri has 3 phases. So it goes up, down, and up again. So this triphasic wave, it looks like a seizure discharge, but it's not. It's just an abnormal discharge it's just abnormal activity we see with metabolic derangements. And so I want to bring this up because it comes up a lot in our report. A triphasic wave, it usually occurs because of metabolic derangement. So the person has abnormal kidney function, or if they have abnormal liver, then you have these triphasic waves. So I think triphasic waves are very tricky because I think it takes a lot of experience to recognize that these are triphasic waves and not seizure discharges. And because you can see this whole page of all these sharply looking things, and if you're not trained, you might think, oh, are they having a seizure? But really, these are just triphasic waves, which are just for a metabolic issue. It could be from infection or a kidney dysfunction. So it's totally not related to a seizure. And this is just what I said. Okay, all right, great. So now we get to do some practice. So does anyone want to tell me what this EEG is showing us? So that's part one. Question part one. What is this page showing us? Oh my God, the fire alarm. Yeah, so Sylvia is completely correct, and I hope everyone can see it. So Sylvia says it's a right temporal seizure. Okay, so let's just orient ourselves again because it's just for practice. So F3 again, it's left midline, right midline, and then here is F7 T3, so left temporal and right temporal, right? So it's a right temporal. So here we see some eye blink, some muscle artifacts. So all this ugly stuff is just muscle. If you're moving around, it's just distorting EEG, all this artifact. And then here, something's going on, right? So there's something sharp going on. There's the typical phase reversal pointing. This is pointing down. This is pointing up. So there's a phase reversal right here, and you can see the amplitude is getting higher and higher. And you can see at some point, like I think I start seeing it here. So the seizure starts in temporal region, and I think it's spreading out. Let's see if there's any more comments. Okay, so Vikram said, yeah, right temporal seizure. Yep, you guys got it. So it's a right temporal seizure. And let's see if I have a next page. Okay, so this is the first page. So this continues. So the seizure starts here, and now you can see it's spreading to the entire brain, right? So the seizure is starting, and then it's getting faster and faster and faster, and the amplitude is getting higher and higher, and now it's spreading to the entire brain. Okay, let's see if there's any comments, any of the comments. Okay, so I think we need to, I'm almost done actually, so great. Okay, what about this page? What is this? What do you guys think this is? Yeah, so this is tricky. This is tricky. Um, so so there's definitely slowing. So I'm looking at comments. So the question is, is this seizure? Is this slowing? So I definitely agree. So the background is slow. So everything is moving very slow. So there's definitely slowing. And just to so this is something I got from so this is another EEG I caught online. So this is left, left, right, right. So, we're used to left, right, but this is very strange. It's left, left, right, right. And so actually, if you look at these sharp waves, they're occurring through, they're generalized. So they're not on the left, they're not on the right. So these are generalized and they have three phases. So 1, 2, 3. So this is 1, 2, 3. So they all have three phases, right? And they're kind of broad. So what are these? These are triphasic waves. So, and the thing about triphasic waves is so tricky, right? So so I know why some of you said, oh, is it right temporal, left temporal? It's because these triphasic waves are not always symmetric. This is one up, one down, one up. So this is triphasic waves. So sometimes they're very symmetric. They look higher on the left, sometimes they look higher on the right. So it's very tricky. It's actually just triphasic waves. It's generalized triphasic waves. Okay, good. All right, I didn't want to trick you guys, but this is just for learning purposes. Okay, all right. So what about this page? What do you guys think this is? Okay. All right, Sylvia. I see your question. I'll get to your question, but first let's just look at this page. What do you guys think this is? Okay, I see Vikram says generalized seizures. Okay, let me see if there's any other comments. Generalized seizures. Okay, Sylvia says artifact. Ding, 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 ding. Exactly, this is an artifact. So here's how you know. So do you see how looks how high amplitude this is? This stuff is really big. That means the electrode is moving around. And the other way you can tell this is the artifact, you can look at the EKG. So we see all this sharp stuff, right? But then if you look down here, it's also in the EKG. So this EEG is from a baby. So the mom is patting the back of the baby. So that's why you can see it in the EKG. So if it's in the brain, it should not show up in the EKG because the EKG leads all the way in the chest, right? I mean, it should not show up here. So because it's showing the EKG leads, this is the artifact. So that's why having the video is very important. If you have the video open, you can see it. And originally I was going to show you the video, but I'm having some difficulty. So it was on my other computer, so I couldn't show you guys. All right, great. So this is just the artifact. So again, this looks exactly like a seizure, almost, right? But the only difference is the amplitude is way too high, and you can see it in the EKG. So down here is the EKG. All right, great. So let's go. So let's go back to the triphasic wave because Sylvia had a question. So triphasic waves it's actually on the spectrum. So triphasic waves, if it's slow, so if it's like about 1 or 2 hertz, we don't treat triphasic waves. But if the triphasic waves start looking like generalized sharp waves, if it looks epileptic, then we would treat it. So triphasic waves it's a very advanced topic, and I didn't want to go too much into detail. I just touched upon it because you do hear about it in your EEG reports all the time. But basically, triphasic waves in general, they're fairly benign, but sometimes, very rarely, if the triphasic waves become very fast, or if the morphology is very abnormal, then sometimes we might treat it. Okay, then that's basically it. Any last questions? I think that's, well, it's 3 o'clock, so we're done anyway. Any last questions?